Hello everybody. Today we are going to discuss about post cardiac arrest guidelines which was published in September 2025. So these are the class of recommendation which are mentioned in this guideline. So class 1 is strongly recommended. Class 2A is moderate recommendation. Class 2B has a weak recommendation, but still up to class 2B there is a more benefit than the risk. The class 3 has no benefit. Then the level of evidence which has mentioned in this guideline, level A high quality evidence based, level B moderate quality. Again the level B non-randomized, it's a moderate quality. Then level C based on the non-randomized observation and meta-analysis, and level C consensus of expert opinion based on clinical experience. So we'll see first what are the oxygenation target which we should maintain in adult patient after cardiac arrest. So it is recommended that we should maintain 100% of oxygen until the saturation or partial pressure of oxygenation is reliably measured in adult patient after ROSC. And it's very important that we should avoid the hypoxia in all the cases of post cardiac arrest patient. Once the oxygen saturation is stabilized, the our oxygen target is should be between 90 to 98%, and PO2 should be between 60 to 105. Now about ventilation targets. So the PCO2 should be between 35 to 45 according to these guidelines. Now what about the blood pressure target? So blood pressure target, yes, definitely we should avoid the hypotension, but the mean arterial pressure should be at least 65 mmHg. Now what about the diagnostic study which we should conduct after cardiac arrest? So yes, so class 1 recommendation goes to ECG. ECG should be obtained in each and every patient or in all adult patient after ROSC. And also 2B recommendation goes to head to pelvis CT scan after ROSC. The importance of obtaining a head to pelvis CT scan is to rule out etiology of cardiac arrest and complication from resuscitation. Also, 2B recommendation goes to goes to echocardiography or point of care cardiac ultrasound to identify the significant cause of the arrest. Now, the most controversial topic is temperature control. So we should activate the targeted temperature management if the patient is unresponsive after ROSC. This should be irrespective of the site of arrest. That means whether it should be intra-hospital or out of hospital, we have to activate or it irrespective of presenting rhythm. That is irrespective of shockable or non-shockable rhythm. If the patient is unresponsive after return of spontaneous circulation, yes, we need to activate TTM. Now, activating TTM means not we have to maintain the hypothermia, but we need to maintain the the more evidence is going in the favor of targeted temperature control. That means the temperature should be between 32 to 37. Yes, and we should avoid the fever in all cases. And so should if the cardiac is arrest is happening out of the hospital, then should we deliberately reduce the temperature of the patient by giving rapid infusion of cold saline? So this practice is not recommended. So once we have maintained the temperature between 32 to 35, we need to maintain this target temperature at least for 36 hours, and after that we have to initiate the rewarm. But there is fixed target. There is a fixed target for achieving rewarming also. Rewarming should not be more than 0.5 degrees Celsius per hour. It should not be rapid. So there is no specific temperature for to maintain this for this target temperature management. But yes, we need to maintain the temperature between 32 to 37. Yes, and this we have to maintain for 36 hours. For rewarming, remember, rewarming should not be very rapid. It should be 0.5 degrees Celsius per hour. Fever we should avoid in all the cases. And yes, targeted temperature management is beneficial if the patient is unresponsive after ROSC and is not following our commands, and this should be irrespective of the site of arrest and rhythm. Now about the additional treatment in adult patient after cardiac arrest. So remember, there is no use of prophylactic antibiotics. Also, there is no role of adding agent to mitigate neurological injury after ROSC. Also, there is no role of steroids after ROSC, and the about sugar target, we should maintain the HGT between 140 to 180. Please remember, we should avoid the hypoglycemia and hyperglycemia. About the use of vasopressors in adult after cardiac arrest. So there is no specific recommendation to use any particular vasopressor. There is no recommendation for using norepinephrine. There is no recommendation that they are saying norepinephrine is choice of vasopressor or vasopressin is the choice of vasopressor. But yes, we need to definitely avoid the hypotension by use of the vasopressor. Now about the PCI, that is percutaneous coronary intervention, when we should activate in adult after cardiac arrest. So they are saying after ROSC, if our ECG is showing ST segment elevation, then no doubt we have to take this patient for percutaneous coronary intervention on emergency basis. But if the patient is not showing ST segment elevation, if your ECG is not showing ST segment elevation, and if the patient is in cardiogenic shock, or by history, if you are suspecting there is a cardiac etiology for this, and or if the patient is having unexplained left ventricular systolic function, then we have to take this patient for PCI. But the question is, should we take take this patient for PCI on emergency basis, or should we wait? So class 1B recommendation goes to taking patient for PCI on delayed basis. That means they are saying at least you should finish this coronary angiography thing at least before the discharge. But yes, class 2A recommendation is going for the emergency coronary angiography. So I hope this point is clear. If the patient is presenting with this STEMI, yeah, definitely we have to take this patient for emergency coronary angiography. But yes, if the presentation is like ECG is not showing any evidence of ST segment elevation, but if you are suspecting it by history, by like patient is in cardiogenic shock, patient is having persistent arrhythmias and the left ventricular function is reduced, then we have to take this patient for we have to take this patient for definitely for percutaneous coronary intervention. But there is class 1 recommendation for taking this patient for PCI at least before discharge, and class 2A is going to the, and the level of class 2A is going for the emergency coronary angiography. Now about the temporary MCs. So they are saying if the patient is having patient is recovered from the cardiac arrest, and if the patient and if mechanical circulatory support devices are indicated, then definitely we should go for it. But they haven't mentioned which device is better. But yes, for the refractory cardiogenic shock after cardiac arrest, temporary mechanical circulatory device we should consider. Now about advanced neuromonitoring in adult after cardiac arrest. So there, the usefulness of monitoring ICP, cerebral blood flow, brain tissue oxygenation, jugular venous oxygen saturation in adult after cardiac arrest is not well established. Now about seizure, myoclonus and other epileptiform activity. So it is recommended to promptly perform and interpret EEG for diagnosis of seizure in adult patients who do not follow command after ROSC, because it could be non-convulsive seizure. And it is recommended that we should treat the clinically apparent seizure in adult patient after RSC. So the treatment of non-convulsive seizure is reasonable in adult patient after RSC. Monitoring EEG repeatedly or continuously is reasonable who do not follow command after RSC. So the same anti-seizure medication used for the treatment of seizure caused by other etiology may be considered for seizure in adult patient after RSC, but they are saying we should not go for non-sedating anti-seizure medication because it may cause more harm. Then, so again, we'll see this recommendation for seizure. So, what they're saying is if our patient is having cardiac arrest, this patient is recovered, and if the patient is not responding, then keep the possibility of non convulsive seizure in mind and go for EEG, and also properly interpret that EEG. And if there is clinically evident seizure, then no doubt we have to treat that seizure. And if EEG is showing the evidence of non-convulsive seizure, yes, we need to definitely treat it. But while treating, keep in mind this don't use this sedating anti-seizure medication, but preferably go for the non-sedating anti-seizure medication. Now, about the diagnosis and management of myoclonus in adult after cardiac arrest. So it is recommended that promptly performing and interpreting EEG for the diagnosis of seizure in adult patient with myoclonus after RS. That means if the patient is having myoclonus, then that doesn't mean the patient is seizing only. So if you are seeing the myoclonus in RSC patient, then go for EEG. If EEG is showing evidence of seizure, then only treat. Otherwise, don't treat just to suppress the myoclonus. Now about the general consideration for neuroprognostication in adult patient after cardiac arrest. So, yeah, if the patient is having cardiac arrest, if this patient has achieved ROSC, then one of the most important factor is neuroprognostication because the entire course of the ICU stay, hospital stay depends on the neuroprognostication. So, how to perform this neuroprognostication? So they are saying the comment about neuroprognostication only after 72 hours. Before 72 hours, there might be many confounding factor which might cause this which might cause a lot of interference in the interpretation of this neuroprognostication. So, if you want to give any definitive comment on neuroprognostication, or if you want to interpret the neuroprognostication properly, give the time of at least of the 72 hours, because before that there might be many confounding factor which might cause wrong interpretation. Now about the clinical examination, which are suggestive of unfavorable outcome. So if our patient is having absent pupillary reflex, if the patient is having not showing any, if the patient is having abnormal reading on the pupillary, and if there is absent corneal reflex for more than 72 hours, then it is going towards unfavorable outcome in adult after cardiac arrest. So also it is the usefulness of undifferentiated myoclonus as a predictor of unfavorable outcome in adult patient who remain comatose is uncertain. So we cannot say if there is a myoclonus, just patient is having myoclonus, and then the prognosis of this patient is going to be bad. So also the usefulness of the best motor response in upper extremities of absent and extensor response as a predictor of unfavorable neurological outcome after cardiac arrest is uncertain. So there are only if we are considering clinical examination, then if there is absent pupillary reflex and corneal reflex for more than 72 hours, then definitely it is a sign of unfavorable neurological prognosis. Now what are the clinical examination which is suggestive of favorable outcome? So yes, the usefulness of quantitative pupillometry to support the prognosis of favorable neurological outcome is not well established. It may be reasonable to consider withdrawal motor response or better to support the prognosis of favorable neurological outcome in adult patients who remain comatose after cardiac. Now let's see about the serum biomarker and its role in neuroprognostication. So there are two serum biomarkers, which is neuron-specific enolase and neurofibrillatory ligament, which we have to measure within 72 hours for predicting for predicting neurological outcome. So we have to measure this neuron-specific enolase and neurofibrillatory ligament at 24 hours, and then we need to see its trend at 72 hours. If it's increasing, then definitely the prognosis is going to be bad. Then, when evaluated with the other prognostic sign, it may be reasonable to consider normal level. But if the neuron-specific levels are normal within 72 hours, then that is the sign and allow means this finding along with the other findings, we can say the neurological outcome for this patient is going to be the good. Now, electrophysiology for neuroprognosis for unfavorable outcome in adult after cardiac arrest. So, when evaluated with other prognostic sign, if the patient is showing only one episode of seizure, then we cannot say the neuroprognostication of this patient is going to be bad. But yes, if the patient is in status epilepticus, which has lasted for more than 72 hours, and and if and it may be reasonable to consider, or if there is a bird suppression on EEG which is lasting for more than 72 hours, then yes, definitely the prognosis of this patient is going to be bad. So when evaluated with other prognostic tests, the usefulness of rhythmic and periodic discharges to support the prognosis of unfavorable neurological outcome who remain comatose is uncertain. So, and also, if we are going for the somatosensory evoked potential and there is an absent cortical N20 waves for more than 48 hours after cardiac arrest, then uh, uh, then this then we cannot comment whether the prognosis of this patient, yes, then we can comment it is one of the sign that prognosis is going to be unfavorable. So let's see what are the electrophysiological evidence for the unfavorable prognosis. So one episode of seizure doesn't mean anything, but yes, if the patient is in status epilepticus for more than 72 hours, or if there is burst suppression for more than 72 hours, and if you are finding this rhythmic and periodic discharges, and if you are planning to go for somatosensory evoked potential, and if there is a absent cortical N20 waves for more than 48 hours, then all these are signs for the unfavorable neurological outcome. Now, electrophysiology for neuroprognostication of favorable outcome. So, when evaluated with other prognostic sign, it may be reasonable to consider continuous EEG background without discharge within 72 hours after cardiac arrest to support the prognosis of favorable neurological outcome. That means if the patient is having has recovered from cardiac arrest, and if we are planning to go for EEG, and if the patient is having continuous background without discharges within then for 72 hours, then the prognosis is going to be good. Also, the usefulness of amplitude of N20 waves on SSPE for predicting favorable prognosis is not well established. Now, let's see the role of neuroimaging. So, first neuroimaging is CT scan. If there is a reduced gray-white ratio on CT scan, then the prognosis of this patient is going to be bad. And what are findings we should see on MRI? On MRI, if there is restricted diffusion for at 2 to 7 days, And if there is extensive areas of reduced ADC at 7 to 10 days, 2 to 7 days, then yeah, we can say that the neuroprognostication of this patient is not going to be good. Now, what are the signs for favorable outcome? So as I mentioned before, if there is a reduced gray-white ratio on CT, then prognosis is going to be bad. But if the patient, if gray-white ratio is normal, then prognosis is good, then the answer of this question is not known. So on the basis of reduced gray white matter, we can only say the prognosis is bad. No other comments means on the basis of CT. But yes, if there is a absent restricted diffusion on MRI and if there is absent ADC, then we can definitely say the prognosis of this patient is going to be good. So this is the list of unfavorable outcome and favorable outcome. So first we will see the neuroimaging. First so if there is reduced gray-white matter on CT, if there are extensive areas of reduced ADC on MRI after 2 to 7 days, and if there is extensive areas of restricted diffusion on MRI, then prognosis is going to be bad. About neurophysiology, if there are bilaterally absent N20 peaks on somatosensory potential at 48 hours, and if there is burst suppression for more than 72 hours, status epilepticus for more than 72 hours after cardiac arrest, prognosis is going to be bad. And on the basis of clinical examination, if there is absent pupillary reflex, corneal reflex for more than 72 hours, then or if there is a decreased response on the quantitative pupillometry, yes, prognosis is going to be bad. About serum biomarkers, if there is high neuron specific enolase and high neurofibrillatory ligament within 72 hours, then again it is pointing towards unfavorable outcome. Now, what are the favorable outcomes? If there is absent restricted diffusion on MRI at 2 to 7 days, if there is continuous EEG background without discharges within 72 hours, if there is withdrawal or better motor response, if NSA level is normal after cardiac arrest, then all these signs of favorable outcome. So this flowchart is the summarization of protocol which we should follow after ROSC. So when the ROSC is obtained, manage the airway first, assess airway, place or exchange the advanced airway device as necessary, confirm the correct airway placement. Then we need to manage oxygenation and ventilation. Maintain 100% FiO2. Target SpO2 should be between 90 to 98%. PCO2 targets are 35 to 45. Then manage hemodynamics. MAP level should be more than or equal to 65. Then obtain ECG and also consider CT and ultrasound. Treat the arrest etiology and complication. Consider emergency coronary angiography if there is evidence of XT segment elevation. Then assess the patient of sedation and neuromuscular blockage if possible. Then we need to see whether the patient is following command or not. If the patient is following command, then go for ongoing critical care management and coronary angiography if indicated. If not following command, then along with routine critical care management, go for temperature control, EEG, and coronary angiography when appropriate. Thank you guys for paying attention.